Hi, this is Alexandra Rogers here to present the 6-month data from the eCoin pivotal trial. I'm grateful for Valencia Technologies striving to deliver neuromodulation to the masses, focusing on the UUI indication. This study involved 6 urologists and 9 urogynecologists who knocked out 133 implants in 7 months' time. The procedure was designed by Dr. Subro Sen, a plastic surgeon specifically trained in peripheral nerve and extremity surgery. He placed an emphasis on reproducibility and safety. Here is my one disclosure. The eCoin is a leadless, flat, nickel-sized device which has both a primary battery and a very forgiving electrical field. There is a cone-like stimulation output delivered from the center cathode to the anode electrode at the outermost edge. It is a 20-minute procedure performed in the office or ASC. 2 unique tools are used, a template and a blunt dissection tool. These ensure consistent coin placement and pocket creation. The automatic low-duty, intermittent 30-minute stimulation avoids compliance and maintenance issues seen with sacral neuromodulation, PTNS, and other emerging tibial implants. It reduces office visits compared to PTNS and Botox potentially. The study involved 133 subjects. For inclusion, patients had to have a PVR less than 150 cc's. Careful leg evaluation was performed to look for symptoms of neuropathy and claudication. We also checked for pedal pulses and pitting edema. These are patients who had failed prior OAB therapy except for prior sacral neuromodulation implant with washout periods applied. For exclusion, patients could not have bladder pain syndrome or neurogenic conditions such as MS and Parkinson's disease. As previously described, we excluded leg conditions at risk for poor wound healing. This is a simple and fast experience with no need for C-arm or ultrasound. It is modest and intimate. Although placement is more specific compared to sacral neuromodulation IPG surgery, the procedure has a short learning curve and should allow for an efficient workflow. Here is a quick overview of the procedure. The foot is placed at 90 degrees. The center of the medial malleolus is marked. The template is placed parallel to the tendon. One can also palpate the sweet spot where the coin will eventually lie. Local injection is given and a thorough prep is performed. During this time, I inform the patient about post-procedure restrictions. The toes are covered. A 3-centimeter incision is made. Blunt dissection is performed down to but above the fascia. The blunt dissection tool is used to make the pocket with the finger used as a backstop. Saline flush is used and the eCoin is put in the pocket. A fascial stitch is placed to prevent migration into the wound and a multi-layer closure is performed. A tegaderm is applied and a compression sock put over the foot. We anticipate standardized kits similar to a central line that can be placed on the Mayo stand. Note, I use no cautery, narcotics, or IV antibiotics in my 26 implants. Patients used a shower bag for 2 weeks and a wound check was performed around that time. The compression sock is worn for 4 weeks and vigorous ankle movement is restricted for 8 weeks. The post-op compliance was achievable. A field clinical engineer activated the coin at roughly 4 weeks after healing was achieved with the following stimulation paradigm. After being activated, the therapy is truly set it and forget it. It's seamless maintenance. It's an automatic therapy with no patient involvement for an average of 3 years with the pivotal battery. Voiding diaries, subjective intake, and safety review were performed at the following intervals out to 48 weeks. In regards to demographics, these were your typical overactive bladder patients. They were highly bothered and had an impaired quality of life due to their syndrome. On average, they went to the restroom 10 times a day and had 4.3 urinary urge incontinence accidents per day. For disposition, 97% of enrolled patients were implanted. There was no trial procedure or screen that excluded eCoin implant. 12 out of 15 doctors were new to the procedure. Prior to implant, patients used a non-invasive, inexpensive, reusable, and understandable TENS unit at the tibial nerve. Those with a 30% reduction in urgency symptoms after 1 week on therapy were considered TENS responders. 63% of the eCoin subjects were TENS responders prior to implant. For the responder rate, 71% of implants were at least 50% better, 46% were 75% better in their UUI, and 25% were dry, with the TENS cohort trending 5 to 7% better. The mean and median drop in UUI are shown here. The median reflects that responders are doing very well, with the TENS responders doing even better with the eCoin therapy. The daily drop in UUI reflects a slow onset of action, but sustained drop of minus 2.73 UUI from 8 to 24 weeks and minus 3 for the TENS cohort. In both groups, bothersome symptoms were greatly reduced and quality of life significantly improved. When looking at the PGI-I, 77% of all patients reported being better or above. Of the TENS cohort, 82% reported being better or above. Both of these line up with the objective change. 12.8% of patients had mild to moderate initial wound issues, including cellulitis and poor granulation of the incision. 7 explants were performed for a rate of 5.3%. 2.3% total were removed for infection. It should be noted the coin can travel up the nerve with no change in efficacy, and there are typically micro anterior and posterior movements prior to encapsulation. Here's a picture of a patient immediately after implant and at 8 weeks. Overall, at 6 months, successful therapy outcomes are seen in both the full and TENS cohort, which trends better. Larger numbers might elicit more information on the predictive value of the non-invasive and inexpensive TENS trial prior to an eCoin implant, and improve counseling prior to the permanent procedure. Explants for infection were well within the norm for FDA neuromodulation safety and efficacy data. This radically novel form factor does not intimidate patients. It is posed to become a dramatically appealing choice, in my opinion. Providers can consistently deliver neuromodulation using minimal resources. Excellent efficacy is achieved without a trial or screen. The therapy is automatic and sustained for years. We can potentially better penetrate this vastly undertreated population, not well managed, and avoid current burdensome and/or undesirable options often compromised by poor adherence.